So 28-year-old patient has been referred to your clinic with a neck lump and diarrhea. How will you assess the patient? It is necessary to exclude the medullary thyroid cancer. Take a history. How long lump has been present? Associated symptoms like hoarse voice, difficulty breathing, difficulty in swallowing, frequency of diarrhea, family history of endocrine disease. Then I will perform examination, neck examination, lymph node, general examination for looking for evidence of Cushing syndrome, metastatic disease. Then diagnosis, neck ultrasound scan, including lymph node assessment and FNAC by experienced radiologist. FNAC diagnoses medullary carcinoma. What is the medullary thyroid cancer? It originates from parafollicular C cells, neurolectoderm. It is often multifocal, more common in the upper poles. It can be sporadic, 80%, and familial, 20%. It's dominant. It's also dominant in men 2A and men 2B. The tumor secretes calcitonin as well as other hormones CEA, serotonin, and prostaglandin, and can cause carcinoid syndrome. Mutations in the RET proto-oncogene chromosome 10 are classified into the discrete subtype which offer underlying degree of risk. It spreads by lymphatics to regional nodes and via bloodstream to the distant sites such as the liver, lungs, bones. And how would you prepare this patient for surgery? So check CEA calcitonin level, check vocal cord function with flexible endoscopy, assess for other endocrine neoplasia associated with medullary thyroid cancer, primary hyperparathyroidism, check calcium, parathyroidism, and vitamin D. Pheochromocytoma, perform 24-hour urinary metanephrines or recombinant plasma metanephrines. If regular lymph nodes are involved or calcium more than 500 picogram, CT scan neck and chest, and MRI is needed to look for the distant mets. If patient has raised plasma metanephrines, then imaging is suggestive of a pheochromocytoma. Which surgery should be performed first and why? The pheochromocytoma should be removed first, preceded by adequate alpha blockage to reduce the risk of hypertensive crisis during medullary thyroid cancer. What is your operative approach for medullary thyroid cancer? This patient needs total thyroidectomy with multicentric bilateral disease and central neck dissection, excision of the delphin lateral nodes. If positive lateral neck nodes, then selective modified radical neck dissection on that side. How will you follow this patient up? So serum CEA and calcitonin every 6 months. Serum CEA also raised in colorectal cancer as well. So serum CEA and calcitonin every 6 months for 3 years, and then annually if raised indicates recurrence or metastatic disease, can be treated with tyrosine kinase inhibitors. Annual check as appropriate. The patient's newborn baby has RET mutation consistent with M2A. Would you offer surgery? If so, when? Current guidelines suggest prophylactic thyroidectomy should be offered, and the timing of the prophylactic surgery depends on the level of the risk according to the specific RET mutation. Thank you.